them in the chat. Questions, put them in the Q&A. And Dr. Comrade, take it away.
All right. Thanks so much, Helen. I appreciate that nice introduction. And even though for the last several years I've been doing mostly Zoom talks all over the world, as a matter of fact, it's always a little bit disconcerting not to see any faces, although I get to see Helen's face. So Helen, you're going to be a stand-in for everybody. So thank you very much for having me back. Actually, this is probably the 8th or 9th or 10th time that I've been with you over the years. And I've actually gone all over the country to do these kinds of talks, and also a similar talk to the one I'm giving this afternoon for NAMIs. And I just want to tell you just a couple of words about how I came to do this kind of thing and who I am. I'm a practicing psychiatrist, and you heard a little bit about my credentials. Right now, most of what I do is see patients in my office. I'm also, by the way, have a whole other angle to my career, which is as a medical ethicist, where I do a lot of teaching and lecturing and workshops around the world. I've also kind of gotten somewhat into some activism as a result of a certain ethical issue, which maybe we'll get into if it comes up. I don't want to take a side trip there now. But perhaps most relevant to why we're here today doing this is that in the late 90s and early 2000s, I had a radio show that went coast to coast. Had about 43 million listeners, and it was Comrade on Call. And it was a 2-hour live radio show, talk show, and we'd have callers call in. And for one of those hours, I'd usually interview a colleague on a specific topic that was their area of expertise, and we'd have callers call in and ask that particular expert questions. And then the other hour was always open phones, which, interesting, was always the most popular hour. And people would call in with all sorts of questions. I mean, whatever they wanted to drop on me, from neuroscience questions to medication questions, diagnostic questions, to social psychology, how to work the mental health system, insurance. I mean, pretty much the entire 360 degrees of the things that we need to encounter when dealing with the kinds of problems that we're all here to learn more about. But one of the most common questions I got asked was something like, my brother, my grandmother, my son, my best friend is troubled, and clearly more troubled than I know what to do to help them. How do I talk to them and convince them to get professional help, to see someone like you, a mental health professional? Because indeed, many people have recognized that is indeed the tough first step. Whatever other problems we might have in accessing care with manpower and finances and insurance and so forth, actually, we are really understanding that one of the biggest bottlenecks is actually having people willing to get in the door.
Yeah, so, and if I can jump in, there's going to be another session later this afternoon that is very specific to that topic. So the title for that talk is How to Convince Someone to Get Psychiatric Help. That's going to be at 2:20 this afternoon. So if you're interested in that one too.
I know the presenter very well.
Yeah.
And it's me.
Oh, so wait, you're doing the same one, that one too?
I'm doing that one too, because
Right.
what I wanted to just finish up saying in this introduction is that as a result of answering and brainstorming with people on the air, what have you tried? What kinds of things, and teaching along the way, including things to discuss with your loved one, and maybe if there's a treating doctor already, to talk with them. I said several hundred of those kinds of calls over the years, and then that became sort of a special interest of mine, and people would come actually from all over the country to consult me about how to convince a loved one to get help. And I put everything that I've learned into this book, You Need Help, a step-by-step plan to convince a loved one to get counseling. So I'll talk about some of the ideas from this book this afternoon at 2:20. But the reason I told you this story is because I really see this opportunity to be kind of an open phones, like I used to do on the air, where you can ask me anything you've ever wanted to ask a psychiatrist, but perhaps didn't have the time or the access. So I am standing by, and
we've got questions rolling in, so we can jump right in with them. Let's see. So we've got What are your thoughts about ECT compared to TMS and emerging treatments like ketamine?
Right. Okay. Excellent question. And I'm going to warn you all that I will over answer questions because I really like to take an opportunity to use a question to teach as much as I can. So let's begin with ECT. ECT, unfortunately, is one of the most misunderstood and maligned treatment in psychiatry, which unfortunately, that's most unfortunate to malign any treatment, but particularly ECT, because ECT, when used properly in the right circumstances, can be one of the most effective treatments that we have in psychiatry. And, you know, many mental health professionals who have sent patients for ECT have said, if I've ever seen anything close to a miracle in my career, it was after somebody's gotten ECT in terms of how dramatic the improvement is. Unfortunately, there's not only a great deal of malignment, and by the way, Hollywood hasn't helped. The infamous movie One Flew Over the Cuckoo's Nest. When that movie was made, it was portraying ECT as it was 40 years before. I mean, it was already out of date the way it was portraying it, and it also portrayed it somehow as a form of punishment. Modern ECT looks very different than in that movie. It's done under general anesthesia with muscle relaxants and electroencephalogram and so forth, and is you know, far less dramatic. And unfortunately, this has led me, in my book, actually I have a little appendix about One Flew Over the Cuckoo's Nest, which I call the deadliest movie ever made. Why? Because so many people whose lives could have been saved with ECT have refused to take ECT because of the scary, inaccurate images of that movie and have lost their lives. So I think that movie has done more to create loss of life than any other movie that I've ever encountered. So ECT is an excellent, powerful treatment. It has some side effects, not nearly as many side effects as many people would have you believe, or not as enduring. And the fact of the matter is that we know that there are certain conditions that especially respond well to ECT. However, it's not an easy treatment to do. It involves showing up in the hospital, basically, or an outpatient clinic in 3 days a week, and going under general anesthesia and having somebody drive you in and drive you home and so forth. So, and you know, you tend to lose your memory during the weeks of the ECT, the 2 to 3 weeks of ECT. You don't typically lose prior memory or don't have difficulty having new memories, but during those 2 weeks, we see some, you know, if you went out to lunch with your family during that time, you may not remember that you went out to lunch.
I can attest. My loved one went through ECT and it was immensely helpful, but definitely he had no recollection whatsoever of the lunch we had together at all. It was, right. Yeah, right. It was immensely helpful.
Right. So it's not good to plan ECT around something important that you want to remember, like, you know, your a relative's wedding or something like that. So now we have new technologies now, and has been referenced, that are, you know, that are alternatives to the other mainstays of treatment, which are talk therapies that come in about 300 plus varieties, and medications, which we have numerous medications for each condition that we have. Some of them FDA approved, some of them not FDA approved. But ECT was an alternative to doing that. Now we have two other alternatives. One, which is transcranial magnetic stimulation, and the other is ketamine. Now, let me just tell you briefly about those. Transcranial magnetic stimulation is a treatment that involves taking a very, very complex, powerful magnet, placing it precisely over a region of the brain that is kind of mapped beforehand, that we believe is associated with depression, and I won't get into the neuroscience about it at the moment. And the machine fires off about 30 pulses of magnetic pulses in a second. And it's done while you're awake. You can feel the kind of the tapping on your head. The current protocol takes about 30 minutes or so to do. You're awake and alert. You can sit and read the paper, and you think of it like sitting under the hairdryer, so to speak. Read a book, catch up on your email, drive yourself in, go on to work afterwards. However, the current protocol involves a treatment 5 days a week for about 4 to 6 weeks. So it's very extensive. Now, the exciting thing is just a few weeks ago, the FDA approved a new protocol called the Stanford Protocol because it was developed at Stanford University. And the Stanford Protocol, in many ways, seems like it would be better, but in ways it's even more intense. The Stanford Protocol is each day for 5 days, you go in for 10 hours. And each hour of those 10 hours, you have a 10-minute treatment. And actually the treatment is more pulses per second even. So you have 10 minutes of treatment, 50 minutes of rest, 10 minutes of treatment, 50 minutes of rest for 10 hours. And you do that for 5 days. And then you're done. So would you prefer 4 to 6 weeks every day for basically what amounts to, by the time you register and sign in and have your treatment and leave, about 45 minutes? Or would you go for 10 hours a day for 5 days, which is 50 hours of a commitment? So that's a new alternative. Now, let me just say that we have discovered that that probably ECT is somewhat more likely to work for certain conditions, like clinical depression. It's less, whereas TMS is more likely to work for conditions, compared to ECT, that is, for conditions like OCD, obsessive compulsive disorder, and some anxiety disorders. If you do not respond to ECT, you probably won't respond to TMS. But these days, because TMS is so much easier, and also the protocol for getting evaluated to be prepared for it, and the blood tests and the brain scans you have to have and so forth are much more complicated for ECT. These days, we tend to send people if they're willing, and if they're not too sick, they're not profoundly ill. If they're profoundly ill, we go for ECT. If they're not that ill and we want to use one of these methods, we start with TMS. Now, the other thing that was brought up is ketamine. So ketamine is a medication, but it's not a medication you take by pill. It's a medication that you take intravenously with an intravenous drip, or intranasally with a nose spray. And it's done in a specialized clinic where you have to be monitored. And ketamine produces, some people have, it is on the street, special K, a drug of abuse at far higher doses than are used here. Ketamine has the advantage, it's particularly effective for acute suicidal thinking. We're starting to use it in emergency rooms because it can abort an inpatient admission by turning around suicidality pretty quickly. But there are many specialized ketamine clinics. The protocol typically involves a couple of hours. So you go in, it takes about 30 to 40 minutes to have your infusion. Then they monitor, or, you get the nose spritz, but they have to monitor you for a couple of hours. It can sometimes cause dissociative symptoms, where you're kind of a little bit out of it, or feel a little bit trippy, some people. And it's given, initially it's given a couple of times a week for a few weeks. It's doesn't work for everybody. For some people, the effect wears off pretty quickly, and they have to go in for monthly ketamine treatments. So all of that is being worked out. It's something I will tell you that most ketamine clinics in this country unfortunately, are not being run by psychiatrists. So I'm a little bit concerned, as are many of my colleagues, that people who are not mental health professionals, they are anesthesiologists, sometimes, advanced practice nurses, that may or may not have had any experience with psychiatric disorders, tend to run the majority of clinics in this country. So if you're going to be looking into ketamine treatments, first of all, if you have a psychiatrist, start with that psychiatrist to get a referral to a legitimate clinic that has experience in mental health treatment. And if you're going to go sight unseen and call up a ketamine clinic, make sure that it's a ketamine clinic that is run by a board certified psychiatrist.
Are there any particular ones in the area that come to mind that might be a starting point?
Well, the Greenbrook is a group that is run by psychiatrists, and it has a number of offices around Maryland, and it offers both TMS and is now offering ketamine, at least the nasal spray ketamine. They're doing ketamine. There's a ketamine clinic at Johns Hopkins, but Greenbrook is much more available in different locations around Maryland. So that's where I tend to send my folks.
All right, we've. Sorry, I didn't want to cut you off there.
I'm ready for the next question.
Awesome. So Bruce asks, my son is 52 and has schizophrenia. Are there any DNA tests that might be helpful in treating him?
Yeah, very, very interesting question. So we do know that, as with many 21st century diseases that we haven't made nearly as much headway as we made in the 20th century, many of them, like diabetes, like bipolar disorder and schizophrenia, are complex diseases that are a combination of nature and nurture, and do seem to have a genetic component. So if you have schizophrenia, your identical twin who shares your DNA, so you have the same DNA, has about a 70% chance of developing schizophrenia in their lifetime. What's very interesting is it's not 100%, right? So if it was a strictly genetic condition, then you would expect like sickle cell anemia, right? If one twin has it, the other will 100% have it. Very simple, genetic disease, Huntington's chorea, a single gene. So why is this concordance rate not 100%? Well, because it's far more complicated than a single gene and involves multiple genes. And we know this because we've done some research on families that have had a number of members of the family who have had schizophrenia that are related, although not all members of the family, right? So you can compare the genome of the family members that have it to those who don't, and begin to see the differences. But it may also, it's not just about what genes you have, but what genes are being expressed, what's turned on, what's not turned on, and the regulation of genes. And the way environment turns on genes is really very much the cutting edge of medical science, to try to figure out things that do have a genetic basis. Why does genes get turned on in one person but not in another? And in a way, it's kind of similar to cancer, right? Why do some people who smoke get cancer of the lung and other people not, even though they may have smoked quite a bit? Well, it's about what genes got turned on that caused the lung cell to go haywire and over reproduce in the smoker. And we don't know entirely why those genes get turned on or turned off, whatever as the case may be, in one person as a result of others. At the moment, though, there is really, the situation is far too complicated, with far too many genes and more factors than just the genes themselves to have any guidance clinically from DNA testing. for example, we cannot, as we could, for example, with, say, sickle cell anemia or Huntington's chorea, we could do a genetic test and tell you whether or not you are likely to develop that, well, sickle cell from birth, but Huntington's chorea later in life. And we can tell you that because we look for that one gene. But with mental illnesses in general, we cannot do that. So we cannot test you and say, oh, you have such and such a genes, therefore your children are likely to have this condition. All we can say is statistically, your children have a certain percentage chance. And by the way, if one parent has schizophrenia, the chance of an offspring having schizophrenia is about 8%, 7 or 8%, which seems low, and it is low, which means you have 94% chance of not having it in the offspring, but it happens to be 8 times higher than if you didn't have schizophrenia, right? Because only about 1% of the general population is random.
Yeah, and just a plug for everyone. If anyone in this has not come to one of our NAMI courses, this is stuff that we cover in Family to Family. We go over concordance rates for different relatives. So and again, it's just broad statistics. It can't speak to your specific family situation, but it does kind of give people a lay of the land a little bit about the heritability rates for some of these things. So if that's something you're curious about, definitely check out some NAMI programs for it.
Right. And by the way, my book happens to be one of the books they use in Family to Family. So
yep, we reference it all the time.
So
all right.
So let me just finish the thought here. So nor are there any genetic tests that you can take to say, oh, based on this genetic test, you should have this kind of treatment or this kind of medication. Or based on a genetic profile, we can tell you what the prognosis is going to be. It's going to be a very serious course over the course of a lifetime or a less serious course. So all of that is certainly in the research hopper at the moment, but it's not ready for prime time.
Is that something you see that, maybe 20 years from now, we could do a blood test and figure out there are applications for that now that I'm aware of, but they're limited and they're certainly not for schizophrenia. I've heard about people trying to use it for.
Well, what we have now, which is kind of a whole other topic, but I'll just be brief about it. We have a genetic test where you can do a mouth swab and you send it away, and it gives you some information that can guide the use of medications. Now, they pretend that it can affect the selection of which medication is more likely to work for mood disorders. That data is weak, but what it's much more useful about is predicting dosages of medication and medication interactions. Why? Because these tests, the most reliable tests that come with this panel are so-called pharmacokinetic tests. Those are tests of the genes that are related to the metabolism of the various medications we have. So if you have a gene that causes you to metabolize certain drugs that use a certain pathway quickly, then you can know that in that person, those drugs will be chewed up by the liver more quickly, and you'll have to use higher doses. Or conversely, if those metabolic pathways are, by the virtue of genetics, slower, less robust, then a certain medication that uses that pathway is going to be metabolized more slowly and therefore linger in the body longer, and therefore you need lower doses. And finally, when you know these, how wide or narrow these metabolic pipes are that you can tell from these genetic tests, you can also predict which medications might actually interfere with one another. So if there's a narrow pipe for outlet, let's use that metaphor, and 2 drugs both use that pipe to be excreted, and they're both trying to crowd in there, you can see that they'll affect each other's blood level because they both, if it's a narrow pipe, they both can't get out if they're both using the same pipe as easily as if you only had one of them.
That's a really great analogy. I like that.
That's a good way to understand the utility of these tests. But I will tell you that in general, the attempts to use them to pick a medication that says this is more likely to work, medication A, Prozac is more likely to work than Remeron. That's not a particularly robust finding, and frankly, other clinical clues that we have for making these choices turn out to be just as useful as these tests. So sometimes they're misused to make medication selection as opposed to these dosing and interaction issues.
That's really
all right. I thoroughly over-answered the question.
That's all right. No, we have a lot of medication related questions, so we're going to stay on that theme a little bit. So this is on a two-parter, and I'd love to get a little deeper into the second part because these are things we get in classes a lot. So Lindy asks, when using Clozapine, would an anti-seizure medication be recommended with it? Also, what are your thoughts on the weight loss medications, Trulicity, et cetera, with the use of Clozapine when weight is an issue? So that's one we get a lot. My loved one doesn't want to stay on this medication because they've gained 40 pounds. And that can affect, so many different things, aspects of someone's lifestyle. So, please take it away.
Yeah, this is a very important question. It's excellent. And believe me, I wrestle with this all the time myself with my patients and, our choices. So thinking about Clozapine. So Clozapine is, just to review, an antipsychotic medication. And it is an antipsychotic medication that in its efficacy absolutely stands alone. It's differentiated from the pack. It is absolutely more effective. We can't say about any other antipsychotic medication, it's very commonly way more effective, with one exception, and that is Clozapine, which, by the way, now that you hear that, you might say, gosh, why aren't we seeing more Clozapine? Which is a very good question. Clozapine is underused. Why is Clozapine underused? Because it's complicated to use and it has a lot of side effects. One of the side effects that is rare, but potentially deadly, is that it can drop your white blood count. Remember, white blood cells are utilized for fighting off infection. So, we talk about immunocompromised people, it's because they don't have enough white cells. So that's a terrible outcome. You don't want to see it. It only happens, in less than 1% of people, probably maybe even 0.5% of people. But if you can know that it's starting to happen, you can abort the process by stopping the Clozapine. Therefore, when you use Clozapine, the person who takes it has to agree to having a blood test to make sure it's not happening every single week for 6 months. And then if all is well, every 2 weeks for another 6 months. And then if all is well, once a month as long as they're on Clozapine. And if they're on Clozapine for the rest of their life, at this point, once a month blood test for the rest of your life.
Wow. And during a pandemic, if there's a lot of interesting viruses running around, that can be even more nerve-wracking, I can imagine.
Right. Getting people to go for the blood. I mean, getting people to accept, which is this afternoon's seminar, getting people to accept treatment in the first place is hard enough. But then getting to accept the medicine is even harder, and getting them to accept a blood test every week for the medication, getting stuck with a needle every week is even harder. So it's one of the reasons it tends to be underused. Another is that, like many of the newer antipsychotics, it has a certain set of side effects. The old antipsychotics, that some of you who've been around a while may remember, don't use them much anymore. Occasionally you see them like Haldol, Prolixin, Mellaril, and things like that. Thorazine, going all the way back to the first one, Stelazine. All of those so-called first-generation antipsychotics, all of them had lots of side effects. And one of the most, the kinds of side effects that you would get with them, there were a variety of them, but the most common ones that people didn't like were neurological side effects: tremors, abnormal movements, what we call akathisia, which is terrible restlessness, or tardive dyskinesia, which is movements, tremors, or Parkinson-like symptoms. That was the first generation. The second generation of antipsychotics, the first of which was really historically was actually Clozapine, but that was in Europe. But I'm sure many of you are familiar with all the second generation antipsychotics. So Zyprexa, Seroquel, Geodon, Risperdal, some of the newer ones, Vraylar, Caplyta, those are all second generation. So although they can cause neurological side effects, it's much less common, but they come with their own freight, and that is metabolic side effects, specifically weight gain, diabetes, increased abdominal girth. So this is the challenge of the second generation antipsychotics, and Clozapine is one of them. So what kind of antidotes do we have for that? By the way, one of the, just because it came up in the question, one of the potential rare side effects of Clozapine are seizures. However, it's rare. If you don't already have a seizure disorder, it's unlikely. And in the usual therapeutic dosage range that you use it, as opposed to extremely high doses, which occasionally some people need, it is even more rare. So the risk-benefit calculation of putting someone on a prophylactic, preventative anticonvulsant to prevent seizures when you use Clozapine is not favorable. The side effects of anticonvulsants versus the level of risk that we're talking about just doesn't add up. So no, we do not use prophylactic anticonvulsants with Clozapine. Now, what about prophylactic weight gain medications? So there is some data out there that favors two medications in particular that can be used to mitigate, slow down, if not eliminate, weight gain on all antipsychotic medications, but Clozapine in particular. And that is happens to be an anticonvulsant, but it's not being used as an anticonvulsant in this context, called topiramate or Topamax. And the other one is a medication that you see very commonly used for diabetics, which is metformin. Now, there is some data, particularly in children, on antipsychotics, that if you start children on one of these two medications along with the antipsychotic, it mitigates weight gain. So as a matter of fact, there's a new product now, and the new product is a combination of olanzapine and topiramate. So you can give them together in one pill rather than two pills. It's expensive. It's much cheaper to just prescribe two separate pills. Now, there's a whole very exciting new technology about weight loss for everyone, not just for people who are on antipsychotic medications or other medications that cause weight gain. And the exciting new development are the GLP-1 agonists. Now, they come from the world of diabetes, and you've probably heard the generic name of the most common one is semaglutide. The brand names you might have heard of and seen on TV are things like Ozempic and Wegovy. These are medications that you come in a little injector pen, and you inject yourself once a week with it. And they have really shown some really remarkable ability to cause weight loss with accompanying diet and exercise, which always accelerates things, that are a whole new world of weight loss. Now, what has not been done, and I'm sure there are studies underway, is what if you were to give this weekly injection? I mean, look, you already got people going to the lab once a week for Clozapine. So while they're at the lab, and it's injection give yourself, it's a little spring-loaded thing. Also got your weekly semaglutide, your Wegovy or your Ozempic injection, would that prevent weight gain? That really remains to be seen. It's just too new, and we need to study that. Similarly, we need to study after you've gained the weight, what would happen if you use this? Can you shed it? And as a matter of fact, at the moment, I'm doing my own little private clinical trial with 2 patients who are on Clozapine, and I'm giving them Ozempic, which is tricky because it's extremely expensive. So you have to get the right patient with insurance that's willing to do it, because insurance tends to cover this if you have diabetes, but not if you don't have diabetes. So anyhow,
which is great, because it's like, stay overweight long enough and your chances of developing diabetes are so much higher. So
took the words out of my mouth.
Gotta love those insurance companies. Oh,
is this a great country or what?
Yeah, American exceptionalism at the finest.
All right, next.
All right, so let's see. We've got. Do you have any strategies for encouraging patients to continue to take medications post-recovery or after a second episode of psychosis to prevent relapse? Especially when the patient believes they're doing well and don't need to continue taking it. And any advice for the family of this patient if they're very concerned about a relapse?
Right. It's definitely a common problem. I invite that questioner to come to my my seminar this afternoon, because I talk about some of the way in which families can mobilize their power. Families are often the most underutilized power. It's tempting to rely on the power of the doctor, power of the police, power of the hospital.
That was another part of their question, was also advice for the doctor. So really, there's a lot of ways to go.
Right. So, there are a few things that I think can. Okay. First of all, let me just say that I do not want you to walk away with the idea that every patient who has a major mental illness needs to be on medication for the rest of their lives. Okay. So, for example, major depression. Okay. An episode of major depression, we tend not to, the data shows that there's more recurrent forms and less recurrent forms, right? How do you know? You got to kind of see what happens over the course of a person's life. So that's why we typically don't think of somebody needing lifetime maintenance antidepressant medication until they've had 3 episodes of depression. So there's still a chance that you could go without medication and be okay after the first, and maybe even after the second. But after the third, the chance that you'll have a fourth is 90%. So, that's with depression. And of course, some depressions come with psychosis as a symptom, psychotic depression. And we use an antipsychotic under those circumstances. And so those are examples of people that we may not need to stay on an antipsychotic the rest of their life, right? So that's one thing. Secondly, people may not need the same dose. Let's say you are a person who, by virtue of your specific case, that we've looked at a variety of features that you really should, it would be excellent. Let me just take a quick sidebar here. And that is, what I tell patients is, for many of these medications, like an antipsychotic or a mood stabilizer, like lithium, in the acute phase, they're kind of like taking an antibiotic for pneumonia, hit the acute condition, okay? After the acute phase, to continue them, they have preventative effects, right? So, not lithium, not just because you're acutely manic, but as a mood stabilizer to prevent further episodes. So in that phase, they're more like Lipitor for cholesterol to decrease your risk of try to prevent strokes and heart attacks, or high blood pressure medicine that you take even when you're well. in order to prevent adverse outcomes. So I wanted to get to those metaphors, those comparisons, because one of the ways in which I talk to patients about, why should you stay on the medication is by making those analogies. Sometimes patients are already on blood pressure medicine. So, well, why are you taking blood pressure medicine? Does the blood pressure hurt? Does you have symptoms from it? No. But then why do you take it? I take it because, my doctor said if I don't, I'm more likely to have a heart attack or stroke. I say, okay. So by the same token, if you continue to take your antipsychotic, that is working the same way for prevention. So, but also we may not need as high a dose in the maintenance phase, or the preventative phase, or the relative remission phase. By the way, that's a significant difference between bipolar disorder and schizophrenia, and its related schizoaffective disorder is typically bipolar disorder. When it remits, it remits. You're well for the most part in between. Maybe just little residual symptoms or blips, but for the most part, it's just why I always thought that bipolar disorder should be called tripolar disorder, because it has 3 poles, right? Mania or hypomania, depression, and then euthymia. Okay, right? So that's sort of the third. It's a 3-state disease, not a 2-state disease.
I think there's probably a lot of people who have observed their loved ones, including me, who'd agree with that. That sounds about right.
And by the way, that's a problem for this question of maintenance treatment, because during those remission periods, people say, I'm well, right? And they lose the opportunity to have a prevented, and particularly in bipolar disorder, we have this phenomenon called kindling, like a fire, right? So imagine a cigarette dropping on the couch, and first the couch is smoldering, and then the couch catches on fire, and the longer you let it burn, then the wallpaper's on fire, then the roof's on fire, and before you know it, you have a 5-alarm fire. But if you could put it out early, right, you might not even, the fire extinguisher may be enough, right, or a watering can may be enough. Similarly with bipolar disorder, the more relapses you have, the more severe the relapses get, the more frequent the relapses get, and the less, the more resistant to simple medication interventions you get. And you get into the cases, where you're on 3 medications instead of 1 medication. You're on lithium and Lamictal, and Depakote.
That's a question we get too, is like, well, my kid is on so many medications, and, sometimes we're talking about kids who are 30, but my kid's on so many medications. Is it really okay for them to be taking 4 medications at all times? And
yeah, and the answer is it may have required 4 medications at once. I know we're getting a little bit off the question, but this is important. The easiest thing in the world in my chair is starting a medication. Actually, the hardest thing is getting the person in the door.
And then getting medicated and paid for, but yeah.
Right. But from what the doctor is doing, starting a medication is the easiest. The hardest thing to do is to decide, let's see if you need it anymore, and let's stop it or taper it off. Because look, once you get stability, right? That's a prize. That's quite a prize for everyone, for the patient, for the family, for the doctor. Right? It's we've achieved stability. If it ain't broke, don't fix it. And what often happens, you've layered on one thing, it didn't work, so you layered on another. And by the way, that's also difficult. So when one isn't working as well, you have a conundrum there. Do you stop that one and start something in its place, or do you layer a second thing on top of it, and a third thing on top of it, and pretty soon you've got a stack, right? And we do tend to do layering, because why? Because what often happens is a medication gives some response, not zero response. Medication gives zero response, you discard it, but usually it gives some response. So you don't want to pull the rug out from under the person and lose that some response while adding a second medication. So that's how you end up getting stacking. But peeling off the stacks, now that is a clinical art, right? And what it needs, now this allows us to get back to the question. Okay? What it needs is the single most important, the medically active ingredient to help people stay adherent to their medication prescriptions and their other therapies is a robust and enduring and adequate relationship with the treater. Many of my chronic psychotic patients, okay, I have a superb relationship with them. Why? Because we sit together for a half an hour every single week, right? So by the end of the month, we've sat together for 2 hours. For some of the, occasionally even an hour, but for people like in that situation, I typically do a half an hour every single week. It's part of, and so we have a relationship. And by developing what we call in technical terms, the therapeutic alliance in this way, that really is the fundamental basis in which I can work with people to do things like convince them to stay on medication, like, should we try something new, or should we peel something off, or things like that. So besides all the things that I've spoken about before, like, the analogy to high blood pressure and so forth, having a relationship with, and if it can't be with a psychiatrist, then with another mental health professional who's on the team with a psychiatrist. I actually see one of those colleagues here in the audience, and she and I treat a number of patients together. And let me tell you, it takes a great deal of teamwork. So at least one, and hopefully in our cases, both have a frequent encounters with the patient. So dropping in every 3 months, that's not treatment, that's gossiping.
So for that specific question about like how to encourage your loved one to stay on the medication after recovering from a psychotic episode, it really has to do with like FaceTime, literally, ideally, with their provider to kind of keep them connected to the treatment. Is that?
Yeah, that is use the Latin, sine qua non, that without which the rest of it is difficult to do.
Excellent. All right. So we have about 10 minutes left and we still have a bunch of questions. So I'm going to pick a few that are on a theme here. We've got a few questions about Seroquel. Let's see. What are your thoughts on off-label use of Seroquel for treating sleep issues in people with anxiety and depression? Can it cause long-term effects like weight gain and increased risk of diabetes? And then another question we have about Seroquel is, let's see, where is this one? Do you have you known patients who experience teeth clenching, muscle spasms after taking Seroquel? The patient's been on it for like 10 years. Symptoms only present at night after taking it. Supposedly ruled out tardive dyskinesia. And on that same theme, we have another question about how often should a provider be testing for involuntary movements on certain drugs?
Right. Well,
that was a bunch to unpack, but
we work backwards. In the last question, every single visit, right? I mean, every single visit, I'm observing the patient, and I may ask him to do, some maneuvers if I'm beginning to see things. So, that's part of one of the reasons why follow up during the pandemic over the telephone was not really adequate. Zoom, at least we can get some partial things. It's difficult to see what's happening with the lower extremities, of course. So the answer is we're looking for that stuff every single visit. The second question about the emergence of adventitious movements like jaw clenching and so forth late in the game, right? And we know that some tardive dyskinesia is called tardive dyskinesia because the word tardive means slow to develop. So they come on late. And yes, even the new generation antipsychotics like Seroquel, which is also the generic name Clozapine, that those days can lead to tardive dyskinesia. And particularly as people age, they become more vulnerable.
Is dosage really important to the likelihood of that developing?
Yes, the dosage is important for that to develop, for that risk. And let me just say that from what you describe, I can't put together, because what you describe sounds, I mean, I haven't seen the patient, so much like tardive dyskinesia that I don't understand the additional thing in that sentence. They say he doesn't have tardive dyskinesia. To me, that sounds like tardive dyskinesia. But whatever you call it, it's a late onset motor movement, which frankly is the definition of tardive dyskinesia.
And would that reaction, that would be time limited to the when they're taking the medication? Because I think of a lot of that as something that continues after it's developed.
So it can. And you can try a lower dose. By the way, changing to Clozapine might be something to discuss, with that particular doctor, because Clozapine actually is one of the treatments for those kinds of movements. Now, going to the anxiety and sleep, the use of Seroquel off-label. So first of all, let me reiterate that most of what we do with psychiatric medications is off-label. Most of what we do is off-label. Very few think, to get something on label costs $1 billion. Okay, so a new medication comes out. The drug company, literally, I'm not kidding. This wasn't an exaggeration. It costs $1 billion to get a new drug in the market. That's why new medications are so expensive. It takes a pharmaceutical company years to make their money back unless they have a super, hit. So once a medication is out for a while and becomes generic, right, then there is no financial incentive anymore to get a new indication for it. Meanwhile, it's been out there, and a doctor is allowed to use a medication for anything. You don't have to use just what the FDA says you have to use it for. You have to tell the patient it's not FDA approved, but we use it, and then it's shown to work, but no studies are done because nobody's going to make any money from it. That's the way things work in America, right? New drug development is not sponsored by taxpayers. It's private industry that develops it, unlike some other countries. So we know that Seroquel, turns out, quetiapine, can be very effective for anxiety and for sleep, and it's used a lot in those circumstances. But Seroquel side effects are Seroquel side effects, no matter what the indications are. So late onset tardive dyskinesia, metabolic problems, weight gain, and so forth. However, the metabolic problems definitely do seem to be dose related. The higher the dose, the more you get it. And we tend to use much lower doses for those indications. So it's less likely. So the typical dose of quetiapine, Seroquel, for, say, schizophrenia is between 300 and 600 milligrams a day. Mm-hmm. Typical dose for sleep, that we use it for sleep, is 25. So it's 1/10 the dose. Mm-hmm. Or anxiety, maybe 25 twice a day, or even 12 and a half. So we're talking about, 1/10 the amount that we use in major mental illness.
We have a lot of questions too in classes about is that really a long-term effect of the drug, or which drug, if you have folks that are on multiple drugs for decades at a time, but also, how do you unpack whether does the drug actually increase your risk of diabetes, or is it the drug does increase your weight and that's what's contributing? So could you separate out sometimes the long-term effects of things? We have a lot of people who ask questions about, what are the long-term effects? Is it worth it to be on this drug?
Yeah, I don't think it's in terms of what the molecular mechanisms are at work. I don't think that's of particular use in this conversation. To simply know that there is a statistical increased chance of weight gain and insulin resistance. By the way, people can develop, just to make a clinical observation, people can develop diabetes on these medications without weight gain, right? So it's not just weight gain, but then you also have to factor in what's the family history, what the genetic risk of diabetes, and so forth. So, is it worth it? Is it worth it? And I think that it's interesting. to have a mental illness, is something that afflicts the most human aspect, the mind. It's one of the reasons I became psychiatrist. I felt psychiatry was the least like veterinary medicine of any specialty, right? All the other specialties, the animals share, orthopedics and urology and so forth, but the mind, okay. So this is uniquely human.
To be fair, a lot of dogs are now on antidepressants as well, but yes.
For behavior.
I see your point.
Right. Not for the complex effects in mental life, which are the domains of thoughts and feelings and behaviors. So and yet we live in a society that places tremendous premium on looks, and just ask the people who specialize in anorexia, right? Have a society places a huge premium on looks. So one of the things that I struggle with is people come already socialized throughout their lives to have feelings about weight and body image, right? But they haven't experienced mental illness until now, and typically it's beginning in late adolescence, early adulthood. Right, which by the way is also a very socially sensitive part of time. So, it's understandable why people would wonder: is it worth the trade-off to have the body I want with the versus the mind I want? And we're working to thread the needle, so that you can try to have the best of both. But as a professor of mine famously said, there are no solutions in life. There are only trade-offs.
Yeah, absolutely. So we are about at the end of our time now. We still have obviously many more questions that have rolled in. I know we're going to try and get some of those to you offline later, but thank you so much for your time. This has been a really enlightening conversation, and I really appreciate everyone contributing their questions here. Is Dr. Comrade accepting new patients? That seems like a relevant one.
Yes, you can go to my website, which is simply comrademd.com.
Right.
Let me say that if you are lucky enough, as many people are not, to already have a psychiatrist, I do not take patients who already have the good fortune of having a psychiatrist, but I do a one-time consultation to give a second opinion that I write up and make available both to the patient and to the treating psychiatrist. And it's also typically about a 4 to 6 week wait to see me as a new patient, but you can go to comrademd.com and learn more about that if you want to find out about that.
Great. And just a reminder, everyone, a lot of the questions that have to do with, how do you get your loved one to take medication, that sort of thing, please come back this afternoon. I think it's at 2:20. Yeah. Come back at 2:20. We're going to have Dr. Comrade again helping us with those questions. So I hope to see you guys there as well. I can keep throwing you questions on if you want to go for another couple minutes.
Sure.
They're not going to
I got off the go. I'm hanging out to my next session.
Excellent. All right. So yeah, there is a lunch networking thing happening. So it's totally understandable if you guys need to head out, but we'll go for another 5. We've got, let's see, is there any increased risk of development of Parkinson's disease in patients who are treated with methylphenidate or other ADHD medications?
Yeah. So that's an interesting question, because there is in certain corridors of psychiatry an association with Parkinsonism. But you have to be careful. So the disease Parkinsonism versus Parkinson-like symptoms. Okay. So
that's actually another question, by the way. So can you speak about antipsychotic or neuroleptic induced Parkinsonism versus true Parkinson? Yeah.
Right. So neuroleptic induced Parkinsonism. See, the disease Parkinsonism is a degenerative disease that occurs late in life. It may have a genetic component, but again, not always. Just like schizophrenia, the identical twin stuff we talked about before. So it's late onset degenerative disease, and just like Alzheimer's is a degenerative neurological disease, or ALS, Lou Gehrig's disease, is a degenerative disease, Parkinsonism. And what it involves is the loss of certain neurons in the brainstem in a region, no relevance, but just out of interest, called the substantia nigra, which is where the majority of the cells in that region are function with dopamine. They signal each other they're loaded with dopamine. So as these cells die off, there's a dopamine depletion. Hence, the first treatment that was ever made for Parkinson's disease is L-DOPA, because DOPA is converted to dopamine, and that basically replaces or has some replacement for the loss of those dopamine cells in the brainstem. So, antipsychotics, one of their effects, and we believe very relevant to their therapeutic effects, is that they block the receptors on which the dopamine molecule binds. So the way nerve cells basically talk to one another is at the end of one cell, it squirts out a little chemical called a neurotransmitter, and it passes across this space called the synapse, and it attaches to a receptor like a hand and glove, on the other side. And when enough of those receptors are attached, it causes the next nerve cell to fire off an electrical signal and move the signal on down to the next nerve cell. So that's called neurotransmission, right? And there's long been a idea that it appears that one component, and it's absolutely not the only component of psychosis, is excessive dopamine transmission, too much of dopamine in these synapses. Turns out there are other features as well, which are leading to some contemporary developments like other neurotransmitters like gamma-aminobutyric acid, GABA, glycine, glutamate, some others. But dopamine is a big one. And all antipsychotics block the dopamine receptor so that all this excess dopamine can't
hanging
bind.
out in the synapse, not landing. Yeah.
Right. So dialing down, this excessive dopamine. So since I've explained to you how Parkinson's disease works, now you can understand why antipsychotics might cause Parkinson-like symptoms, because they are basically down-regulating the dopamine system. But it's not Parkinson's disease, because Parkinson's disease is a degenerative disease where those cells in the brain die. That's not what's happening, right? This is a chemical effect. Therefore, with medications, therefore it's reversible. Or you can give antidotes like benztropine and other medications that can actually help to restore the part of the dopamine system that you want without affecting the part of the dopamine system that you want to dial down, because it's not just dopamine in general. It's where in the brain the dopamine is upregulated versus downregulated. Now, with regard to the stimulants, there's actually not evidence that stimulants are associated with Parkinson's symptoms. I mean, stimulants can cause tremors, for example, but that's not a Parkinson kind of tremor, right? So a stimulant kind of tremor is like this. Okay? A Parkinson's kind of tremor is slow and they call it a pill rolling tremor, kind of like you're rolling a pill in your hands. This kind of slow thing. So even if you look clinically at the effects, potential side effects of stimulants, it doesn't look anything like Parkinsonism. You don't also get the other things like slow walking, slow speaking and movement, rigidity when you try to move the arm like this. These are all Parkinsonian symptoms. So the short answer, which I of course avoided, and so I can give the long answer, is no. Parkinsonian symptoms are not a risk from stimulants like methylphenidate and Adderall and Vyvanse, things like that. And certainly Parkinson's disease is not a risk with long-term use of actually any of these medications.
So when it comes to someone who's, developing tremors as a result of a medication, once they're experiencing those, what's the immediate response? Is that, okay, we need to lower the dosage of that medication, or is there a permanence to that? In what cases is it a temporary thing versus a long-term concern?
Right. Well, of course, it depends on, because the tremors that you might get from an antipsychotic are going to be different than the tremors that you might get from a stimulant or from an anticonvulsant. It all depends on what you can get away with, right? So, is there a option of lowering the dose? What are the risks of lowering the dose? Sometimes you'll lower the dose, and people will have breakthrough symptoms. So you kind of take a step back, right? And then you say, okay, well, that's the floor on your dose. So you're at the floor. Or there's some medications that we're lucky enough to have done the research that have therapeutic blood levels, and you can titrate the dose according to how much is in the blood, because we know that if the level is in a certain window between this value and this value in the blood, that tends to be associated with a therapeutic response. So lithium is the classic example, right? Mm-hmm. So lithium levels between 0.6 and 1.0 is the optimal range, right? So if somebody is doing well and has a lithium level of 1.0 nanograms per milliliter, then there's some wiggle room there, right? Well, I mean, we're at the top of the range there, and you're having tremors on lithium. Okay, I got some room to try to bring you down. Now, maybe this person, needs a lithium level of 0.9 or 1.0. I guess we'll see as we come down. But if their level is 0.6, or even if it's 0.5 and they're doing well, okay, so maybe this person can get away with 0.5, right? Then I'm reluctant to say, let's lower it and see if the tremors go away, right? Because we're at the bottom here, we're at the floor now. So that doesn't give me as much of an option. So in that case, if a person is bothered by tremors, then we might be talking about some of the adding an additional medication that can treat that side effects, like propranolol, beta blockers, are useful for lithium-induced tremors. So just you can, what I'm sharing with you is sort of how one reasons about these things. What are the clinical thought processes that go into these kinds of decisions? And obviously that's going to be different for different people.
Let's see. I was gonna say, if you want to keep going for another couple, we've got, we've got some
people are hanging out. I'm here.
Yeah, I was gonna say, we still got about 20 people here. So, there's a few questions here that I'd love to kind of kick back to you later this afternoon, because they're much more related to like, how do you convince? But one of the ones I want to put in your little hopper now is, how do you convince a loved one to get, dental work or a COVID vaccine or what have you, when you're already struggling to get them in the door for psychiatric treatment. So that's one that I'd love to get on this afternoon too, because, you can have folks that are neglecting all kinds of different aspects of their health. And it's all of it. Okay.
And by the way, it's one of the reasons why people with chronic mental illness have more health problems. And, as a result, they tend to, oftentimes not have as long a lifespan as a result, because they aren't taking care. They smoke more. They don't have primary care. They're not, getting follow-up. They have, potential side effects of the medications that have long-term consequences. So that's why a good primary care team is a very important complement to a good psychiatric care team.
Right. And I mean, it gets into issues of, when your insurance coverage isn't going to help you out with just a routine cavity fill, and you're out of pocket for that, if you're already struggling to pay for medications that are only partly covered by insurance, another $180 to get some cavities filled is maybe outside the range. So it can be really sad. Let's see, we've got a lot of medication questions. So let's see if we can knock a couple more.
Mental and mental only differ by one letter.
Yep.
And yet their coverage differs quite significantly.
Yeah, I mean, and that's one that does, in a weird way, persist in other countries to a point. Like, obviously, we're the only advanced nation on the planet that doesn't ensure access to healthcare to its citizens. So it's a little embarrassing, but yeah, even in countries that do have terrific health coverage, somehow dental seems to be treated separately. And I think that goes back to historically, it was a lot easier for someone with a wrench to just pull stuff out. So the credentials were different. It's credentialing. It's a credentialing issue. Okay, so we've got one. I actually don't know how to pronounce this one. We'll see if I can mangle it here. Could you please speak your thoughts on the use of VMAT2 inhibitors, valbenzaine, and deuterabenzine?
Deuterabenzine, yeah.
Okay. No, give me it again. It's
deuterabenzine.
Yeah. When should it be initiated? Do patients develop a tolerance? If so, after how long? Side effects, issues to consider with use in the elderly?
Okay. Well, that's a very interesting question. And I need to answer this question on the basis of my reading, because this is such a new category of medication, but I have no personal experience using it. So these are medications that actually have been developed to treat tardive dyskinesia. These late developing and yet often enduring. Sometimes they do go away when you stop the medicine, but sometimes they don't. Movement disorders. And I will tell you that, what I'm not entirely clear about is how much of this is economics and how much of this is clinical. But these are, because they're new, they're extremely expensive medicines. So therefore, when it comes, and maybe it sort of makes sense, it doesn't make that much sense when you have an entirely new category of medicine. But in terms of medicines where there are other alternatives, older medications, maybe it makes some sense for insurance companies to have a process where you have to prove to them that you really do need them to spend, $2,000 a month on a new medication, as opposed to, $2 a month on the generic. So that's the level of cost that we're talking about with these new medications. So as a result, the clinical criteria for getting it covered by your insurance companies, you must have a moderately severe case of tardive dyskinesia. There's something called the AIMS scale, AIMS, to rate tardive dyskinesia, and I think you have to have at least a level 8.
8 out of
20. I think it's 20. I'm trying to remember.
That was the question we had earlier about, like, how often should that be assessed?
Yeah, I think, in terms of documenting the AIMS score, we're assessing all the time. And the good thing about a consistent and frequent treater is, I can see, gee, that seems to be getting a little worse, right? In terms of doing an AIMS test and going through all the different maneuvers and writing down the numbers and so forth, go back to that question. I'd say once a year. But so you need a certain AIMS score for an insurance company to approve this, and it's not a cure with all these conditions and all these treatments. Right? It leads to significant improvement. Typically about a 50% improvement in the average in typical symptoms. In terms of how long it needs to be, I do not know that there are any specific guidelines about that, but my expectation is that if you've established tardive dyskinesia as chronic and not unremitting, or the offending agent, like the underlying medication, can't be replaced with something that's less offending, like Clozapine, for example, then probably you're going to need to maintain that medication for the duration. And frankly, that's about all I can say about it, because now we've exhausted my knowledge of that, since it's so
well,
new.
that's a newer one for me. That's, I can usually rip off the pronunciations here, but that one I didn't have down yet. Let's see. We have this is a good one. So
with new medications, by the way, it's always easier to use the brand names.
Yeah.
So Ingrezza, things like that, than these long names. And fascinating how they come up with brand names. It's a whole focus group they do.
Yeah.
They flip different names, and the focus group reacts to it. Anyhow.
It is. It's a whole. There's an entire marketing arm, which is again why our industry is such a fascinating one compared to some other countries where. Years ago, one of my jobs was in processing foreign visitors to the Uniformed Services University, which is the medical and nursing school and dental school for the U.S. military. And so we had some foreign doctors and medical students coming to do some training exercises with us. And I brought them into the ID office to get some paperwork filled out with them. And the French doctor looked up at the screen and was like, "Oh gosh." I can't do a French accent. I'm not going to try. But her reaction to the advertisement for, I think it was Lipitor maybe, on TV was like, "Oh gosh, you're not allowed to do that in Europe. You can't advertise medicine on television." Because again, elsewhere we try and leave it with medical professionals to be recommending drugs. We're not putting it into the consumer's, concept of what they might need.
I'm old enough to remember when that became legal in the United States.
Really?
And how all the doctors, went like this when they started to advertise, ask your doctor about this and ask it. We've come, even further since then, because now everybody consults Dr. Google before they come to the office.
Yeah, gotta love those internet degrees, right? All right, so we have a neat question here, which is one that I'm really curious about myself. My grandmother recently passed away and had Alzheimer's and depression, and kind of watching as her symptoms evolved over the last few years was really interesting to me, of trying to unpack what was causing what. And so the question we have is, what are some keys to deciphering Alzheimer's or other forms of dementia from psychotic depression? How would you determine if an elderly patient with a psychotic depression who has had success in treatment in the past, and how would you determine if they are now developing dementia on top of psychotic depression? How would you diagnose and treat those?
Right. That's a great question, because, one of the things that we talk about, when you do a workup, a dementia workup, somebody comes and looks like they have, symptoms of dementia. What do you explore? What do you rule out? Right. And one of the important points here is that there are some causes of dementia that are treatable, right? Like hypothyroidism, like vitamin B12 deficiency, like folate deficiency, like clinical depression, right? Which is a treatable condition, right? They can reverse dementia, as opposed to things that are really, at this point, we can't really treat. Maybe we can slow down a little bit with some of our medicaments, like Alzheimer's disease or frontotemporal dementia or Parkinsonian dementia and things like that. So, what is the underlying cause? And sometimes depression is the underlying cause. And I think that that the most important thing is to have a person, and just like I don't think that you should go to your primary care doc to find out, or stop with your primary care doc to see if you have an arrhythmia of the heart, right? You need to see a cardiologist to figure out what the arrhythmia is and what are the treatments and so forth, right? So I think that these questions, one might start with one's primary care physician or neurologist, but I think these lie in the wheelhouse of psychiatry, these questions, the way arrhythmias lie in the wheelhouse of a cardiologist. So I think it's very important to consult a psychiatrist who can begin, and the primary care doc can do the thyroid levels and the folate levels and the MRI scans, to rule out a brain tumor, and go down the list of the usual suspects and ruling them out, right? But then the question is, has depression been considered? Right? And I think that's a question for psychiatrists, and there are ways for us to look at that. Now, let me just say that the cognitive presentation in dementia is a little bit different, actually rather different than the cognitive presentation in dementia. By cognitive, that means the domain of executive functionings and memory. Okay, and the cognitive presentation in a depression-caused dementia, we call it subcortical depression. It's not important. Can look like dementia. Is not so much. It's much less fluent, right? In other words, it's a slowness as opposed to a misunderstanding. Okay, so for example, if and this is not the one test to demonstrate it, it's just an example that I'm pulling out. Okay, so if I were to hold this up, okay, and I ask, what is this? Okay, in the picture of depression, a person would look at it, take a long time, and then say, a pen. In the case of dementia, you might look at it and say, I don't know, a hairpin, a pencil is thick. You would misidentify it.
Yeah.
That it would not be typical of.
Well, so that's an interesting one. So we've definitely, both my grandparents had dementia, and I was very involved in the caregiving for both of them. My grandmother passed away just a few weeks ago, and they had some different symptoms, but they both had that slowness. They both had that not understanding what objects were. My grandfather didn't understand what the holiday display in the middle of a table was. He thought it was more food. So you certainly get that confusion. But with the question we had here is about psychotic depression. One of the things that was a little bit surprising for us with my grandmother was the delusions that she developed, where she had this belief that I was moving to Oregon, which we have no idea what relative mentioned something about that. I'm not moving anywhere. I'm definitely in Maryland. But she would develop this delusion and be very sad that I was leaving until I would tell her, no, Graham, I'm still in Maryland. And it was hard to tell whether that was a dementia-related thing or whether that was related to depression, which she had for many years, whether that was a worsening in a way, and what could have been feeding that. So is there a way to kind of untangle when you start to have delusions and that sort of stuff, where that might be coming from? How would you assess that?
Well, of course, you brought up an important thing, which is history. Okay, so is there a history of psychotic depression? People don't rarely have the onset of psychotic depression in old age, right? If you have, in fact, psychosis in general, right? The onset of psychotic symptoms in youth is much more likely to be in the domain of the illnesses that we've been talking about here. In middle age and later in life, you have somebody's psychosis, you don't think schizophrenia, bipolar disorder, psychotic depression. You think organic conditions, intoxications, drug abuse, brain tumors, metabolic, abnormalities, electrolyte imbalances, the early onset of dementia. So the history is important, right? So you're talking about a situation where, okay, somebody has a history of psychotic depression. Okay, so
we're also getting a question. By the way, we do have to actually stop at 10 just because we need to give people lunch before the next session. But we do have a question about, is there a genetic component to psychotic depression?
Yes, actually, a family history of psychotic depression makes psychotic symptoms in the face of depression more likely. So yeah, there is a genetic component to that. But at the end of the day, what you may simply have to do is treat, right? You treat. Look, you're going to need to treat this psychosis, but it depends, on the kind of psychosis and the depression. But if you see elements of depression and psychosis, you treat it, right? And you see what's left. It's a little bit like when people are abusing alcohol. or seriously abusing marijuana, right? And they come in with psychosis or depression or anxiety, right? And I say, look, I don't know. I don't know whether you have an underlying kind of typical condition like psychotic depression, bipolar disorder, anxiety disorder, or is this a consequence of your substance abuse? Yeah. So we're going to hold off on that question until we treat the substance. We're going to get you off the substances, because what you may need is not more medication into your brain. We need to first take something out of your brain before we consider what needs to go into your brain, if anything.
Which is another huge concern with the, it's great that we're decriminalizing marijuana use, but the concern a lot of people now have is whether chronic use from a young age is going to start to affect a lot of different brain development things and increased risk of psychosis. So, all right.
We have epidemiological data to support that worry.
Yeah, exactly. So we may not know that stuff for another decade or more. We're just going to have to look at the data later. But thank you so much. You've been incredibly generous with your time. We really appreciate you going over to answer even more of these questions.